Okay, we're going to talk about the assessment of the mouth and the oropharynx. Here's just a pictorial review of the mouth and the structures. Here's the teeth. A couple things I want to actually just kind of focus on. Notice that there is we're always going to look at the condition of the teeth. The frenulum here and the frenulum at the top. Those are the little connective tissue that's up above and in the below of the gums. The tonsils, ideally we like to look at the tonsils. The hard palate is the palate in the front, versus the soft palate. That's the part that does rise. Obviously the tongue, the uvula. I always hear students call that the little hangy downy thingy. That's the little a piece of tissue that looks like it's hanging down in the back of the throat. So just kind of, because we're going to talk about some of these structures when we talk about the assessment of the mouth. The first thing we're going to start with, again, inspection. You just look at the lips to make sure they're symmetrical. Ideally that we're going to look at the color. They should be nice and pink as in comparison to the tone of the skin. Hopefully there's no edema in the lips or in the mouth. Again, if you have any type of edema with your client, especially in the mouth or the lips, remember that's their airway. That would be a great concern. Any surface abnormalities, any lesions, any problems, do they have free movement of their lips? And you can do some gentle palpation to see if there's any tenderness. Some abnormalities that you may see: cheilitis, that's just inflammation of the lips. Cheilosis, that's the dry scaling or having dry lips, chapped lips. It can also be caused by a riboflavin deficiency. Edema is definitely a concern, whether it's just a localized edema from like an infection, or if it's a systemic edema from a medication and their airway swells. That's much more concerning, obviously. But make sure you make any notation of any edema. Any lesions of vesicles, those are little blisters such as fever blisters or herpes 1. Ulcerations as well, and again, they can be caused by infections, any type of irritations, or even skin cancer. The color of lips should be pink. Again, it has to be in relationship to their the tone of their skin. In dark skin clients, they may have a little bit of a bluish hue or sometimes some freckle pigments. If you see pale lips, again, sometimes when a client is anemic or they have low hemoglobin, you're going to see that more evident in the lips and any of those areas where they would have more of a pink or red hue to it, in the lips, the gums, those areas. So if there's pallor, we always want to be concerned that there's anemia or a perfusion problem. Circumoral pallor, or what they call circumoral cyanosis. Be familiar with that term. That's a term that shows that they're having oxygenation or perfusion issues. This right here, circumoral pallor. I'm sorry, I kind of jumped ahead. Circumoral pallor means that they are really pale, and that might be related to a scarlet fever. If it's circumoral cyanosis, on the other hand, it's more of a bluish or purple hue, and that again, we relate that to cyanosis, or that they are not perfusing or not getting oxygenated, or that there is a significant problem with our client. That's a bad sign. Cherry red lips, ironically, we honestly see that a lot with carbon monoxide poisoning, because carbon monoxide has a higher affinity for the hemoglobin molecule versus the carbon dioxide, and it kind of displaces it. So anytime we see those cherry red lips, somebody comes in from possible exposure to carbon monoxide, fire, or something of that nature, that would definitely be a concern. The teeth, we just do some general inspection, look for any occlusions or any problems with the teeth. The number of teeth, again, we're not going to get this focus on a normal daily head-to-toe assessment unless this is part of the problem. Working as an ER nurse, I can tell you that dental caries or dental abscess, problems with the teeth, we see those frequently in high volumes in the emergency department. I know you probably wouldn't think that, but we do, because they can't get into a dentist over the weekend, or they're in a lot of pain, or what have you. So we do see this frequently, again, from my perspective, from an ER nurse. But as a floor nurse, or if you're working in a different area, this may or may not be, you may not have be exposed to this or may not have to ever do an actual mouth or teeth assessment. But anyway, but we like to kind of just a general number condition of the teeth. I always tell my students that kind of look at a client's mouth, and if they have a good gentle hygiene and look like they take care of themselves, they probably are taking good care of their health. The teeth in the mouth is really, it's kind of like a snapshot of a client's overall health. So it's kind of just got a good idea just to kind of take a good look at those. The color of the teeth, if they've had any dental work, and you just want to do some palpation for stability. Even in surgery, they have to make sure that everything in the mouth, the structures are stable, because if they have to use those artificial airways to protect the client when they're going under anesthesia, they have to assess for those things. So, all right. A normal adult has 32 teeth. Again, some adults have third molars or the wisdom teeth removed. Most frequently, in most adults, they are removed anymore these days. So you do see those. Occasionally, you'll find someone with all their wisdom teeth. I actually have all mine, but I see that most people nowadays actually have all theirs have them removed, at least some of them removed, for lack of space. Some of the abnormalities of your teeth, malocclusions, again, that's kind of when they kind of not grind together, when they kind of overlap. Yellow, maybe tobacco stains. Sometimes also it says yellow or brown, but yellow could also be from coffee stains or tea stains. Caries, that's also called your cavities or dental decay. Usually it starts with like a chalky white, and then it progresses to that brown and then that black discoloration where it looks like it's kind of eating out the tooth. It generally is accompanied by a really foul smell. Excessive wear. Sometimes we have clients who tend to grind their teeth a lot, and it occurs more with aging. And the malocclusions, again, also occur more with aging. You'll see that a lot of times with elderly clients as well. Dentures, again, if they have their dentures and you're doing a thorough mouth exam, have them remove them just to inspect the gums in the oral cavity. Again, well-fitting dentures should not form lesions on gums. I just find frequently a lot of our elderly clients will wear dentures for the first few years, and then they just kind of quit wearing them, and that does cause the gums to recede a little bit. And if they don't wear them frequently, then a lot of times they are unable to wear them because they won't fit anymore. All right, the gums, again, just a brief inspection. That should be pink, kind of like uniform with a buccal mucosa. Look for any type of edema. Sometimes there are certain medications that make the gums really edematous. And look at the tooth margin. See if there's if the gums have receded at all. Just general palpation for any tenderness or bleeding. Again, abnormalities of the gums might be if you see that paleness, remember, because of the hemoglobin it might indicate there might be some anemia from low hemoglobin or what have you. The blue line at a tooth margin, that might be lead poisoning. We really don't see. I have never actually seen this, and we don't use a lot of lead-based products anymore in the United States. But 30 years ago, it was more prominent. Edema within those gums. Again, we're always concerned about gingivitis, periodontal disease because of lack of brushing. Sometimes you'll see little pockets or pouches and like little tiny little abscesses. That might be periodontitis. Overgrowth gums, again, looks like it's overgrowth or edematous. It might be associated with some medications, particularly a Caesar medication such as phenytoin or Dilantin, causes the gums to get really kind of edematous or look really overgrown. And here's just a pictorial of just normal healthy teeth. Some gingivitis, you can see a little bit of wear down at the bottom of the gum line. The periodontitis, you can see the blackish and the decay there. And then there's some advanced disease here in this pictorial. All right, the tongue. Again, you're going to inspect the size, color, if there's any coatings on the surface of the tongue, the surface characteristics of the tongue, movement and tremors, and any symmetry. Hopefully it's symmetrical. The tongue should be red, moist, and when you have them stick it out, move it side to side, move it all around, it should be symmetrical in movement and strength. It should easily fit in the mouth and be held stable. No fasciculation, or it shouldn't tremor. It may have some ruffled edges. That can be a genetic trait for that. Um, on the anterior part of the tongue, that's the top part of the tongue, it should be rough, and you can see the little bitty dots. Those are called the papillae, and you might see some little cracks and fissures. That's normal, just small cracks and fissures. Posterior, that's the underside of the tongue. It might be a little bit uneven, but it should be like kind of smoother, and you might be able to see the vessels under the tongue. They have a thinner mucosa under the tongue. A geographic tongue is just a disorder where it actually looks like a map. It has like these discolored areas on the tongue. They call it a geographic tongue because it kind of resembles a map when you look at it. Abnormalities of a tongue, nodules, ulcerations, indurations, any type of lesions obviously would be a concern. If it's pale, again, we're always concerned about anemia. Anytime you have any of that buccal mucosa, where you can easily see the pink and red tones. If you're a little pale, we're worried about anemia or possible hypoxia. The should be smooth red, or if it is really smooth red and shiny, we worry about B12 deficiency, and that would be on the anterior side of the tongue. An enlarged tongue, first of all, my biggest concern would always be anaphylaxis edema. Again, that might be because of some type of allergy, and it causes the mouth, the lips, and or the tongue to get swollen. If that happens, that's a true medical emergency, because remember, that is the airway, and we worry about what's going on with the lips, and the tongue is also happening within their airway as well. It also might happen with some cases of hypothyroidism and Down syndrome. Our little Down syndrome kids or even adults tend to have a little bit more of an enlarged tongue compared to a child without that chromosomal abnormality. A small tongue may be from malnutrition. Again, not something we necessarily see in this country, but in other places. If the tongue has some atrophy, if it's asymmetrical or has some fasciculations, or that's those little tremors, we always kind of worry about cranial nerve 12, because that is the hypoglossal nerve, and that's kind of helps control the tongue, or there might be some damage going on there. If they have deep, dry fissures, and this is something that you will be looking at on a pretty regular basis, especially with our geriatric clients in the hospital. They tend to get dehydrated really, really quickly, and this is one of the first places you can actually see it. The buccal mucosa, the cheeks get a little bit dry and tacky, and the tongue, you'll start to see dry, deep fissures and grooves in the tongue, and that can indicate that they are dehydrated. Leukoplakia, it's kind of like this white, thick coating that goes over the mucosa of the tongue. You cannot scrape it off. It's really a precancerous condition. We see this frequently in our HIV clients that are actually having some immune problems, that they're like in the stages of AIDS, or the acquired immune deficiency syndrome. They do develop frequently leukoplakia. It's a kind of a precancerous condition. Again, you can't wipe that off. Candidiasis, on the other hand, resembles leukoplakia, but it's kind of a white coating again. But again, you can wipe that off. Again, our HIV clients are prone to getting this infection because the normal flora kind of have rampant growth because they can't fight it off. Or keep things in check. It also happens frequently with neonates, sometimes from feeding a lot. It's basically, they call it thrush or candidiasis, or it's just kind of a yeast infection of the tongue. Again, the leukoplakia you cannot scrape off. The candidiasis you can scrape off. That's how we can kind of tell the difference. And here we go. That's some candidiasis. So here is an adult. You can see the white patchy coating on the tongue. And here is a child. It's that white patchy coating. Other clients that get concerns with with the candidiasis are clients who may be under cancer treatments, or those who are on antibiotics. Anything that might disrupt the normal flora, or the normal flora of the body, which is kind of like the normal organisms that kind of live within our body. The buccal mucosa, or the inside of the cheek. Again, you're just going to look at the color, moisture surface, any type of lesions that might be in there. Look for any abnormalities. You might be able to see the Stinson's ducts. Those are backed by the parotid glands. It might be a little whitish, little pink, little tiny protrusions. Difficult to see, not something that we expect you to be able to identify, but you might be able to see them. If you see those back there, that's what those are. They're called Stinson's ducts. Just palpate for any like masses, tenderness, and just see if there's any an adequate amount of saliva. Abnormalities would include deeply pigmented, if there's any scars, trauma, and if they're having some dental issues, the teeth might have some may cause some changes to the cheek, to the mucosa, if they're having some ulcerations or rubbing on that area for any length of time. And you have the aphthous ulcers, or those are just canker sores, which can happen around little oval ulcerative lesions. They just look like little ulcerations on the cheek. Sometimes they have a little exudate. Sometimes you may see those canker sores, and most times those will resolve on their own. The floor and mouth, or the ventral surface of the tongue, that's the underside of the tongue, that bottom of the underneath there. Again, you're just going to inspect it. Look for the varicosities. And remember, you see all the little veins under there. They shouldn't be overly prominent. Look at the frenulum. Make sure it's appropriate. There's a couple of ducts on there called Wharton's ducts. You might be able to visualize those. And just look at that lateral border of the tongue on the sides. Just general palpation, masses, lumps, nodules, tories. Those are called midline protrusions on the floor of the tongue. It's generally a genetic trait that you might see if people have like Asian descent, or and you don't see them very often, but I believe I have a picture on here. But those are not abnormal. It's just a genetic trait that you might see of those of Asian descent. There might see look for ulcerations, and just check for food particles versus leukoplakia. Remember, the food particles you should be able to wipe right off, versus leukoplakia you cannot. Again, you'll inspect for the palate. We're going to move on up to the palate. You have the hard palate, which is in the front part of the mouth on the upside. You'll see the little lines. Those are called the transverse rugae. And again, you may have some tori up there as well. They're called torus palatis. That is, again, these little bony prominences. It's usually a genetic trait. They look like little bony prominences, and I think I have a picture on here as well. The soft palate is just behind the hard palate, and it's a little bit pinker, and it just kind of like the hard palate kind of flows into the soft palate. And if a child was born with a cleft palate, sometimes you can see the cleft also within the palate, depending on the degree of the cleft palate, or if they've had a surgical repair. You just do a general palpation, and just check, look for, in general palpation, make sure you don't feel for any masses or any clefts or any lesions. There is a picture of the tori. Again, they look like little bony growths up underneath the palate. Again, that's not, it's not abnormal. It's just more of a genetic variation. Again, Eskimos, Native American, and Asians may have this genetic trait. And the uvula, that's that little hangy downy thing, is what my students call that. That's the uvula. We do check for that because that helps us with our gag reflex. And you should, and you won't be able to probably do this unless you have the items at home, like a tongue depressor or a popsicle stick. But we do assess a gag reflex quite frequently, and that kind of involves this area, including the uvula. That uvula should be midline. It kind of comes off the back of the soft palate, and it just kind of hangs down there. It should be midline, should be symmetrical. If it's bifurcated, it might have been left over from a cleft palate. When you have your client stick out their tongue and say, ah, that uvula should rise. And once they do that, you're going to, if you can test for your gag reflex, you would take your tongue depressor or your popsicle stick, whatever you may have, and you just barely kind of touch that back area, just on the back of the tongue or the uvula, and it should kind of make them gag. That is a reflex that we need to check for. Again, it's going to check for the cranial nerve 9 and 10. frequently, because of either injury or because of anesthesia, we numb those areas, or physicians will have those areas numbed, coming back after certain procedures. And we need to make sure that our clients always have a good gag reflex before we reintroduce food or water to our clients, or they can aspirate that food or water. So be familiar with how to assess for a gag reflex. Very important. Again, we don't have the supplies available right now since we have an online class. But again, if you ever want to practice this, even this fall when we get back to campus, do not hesitate to reach out to myself or Dr. Nichols, and I'm more than happy to grab a fistful of tongue depressors and let you practice to your heart's content. The tonsils, again, are they present or have they been removed? They're kind of not removing them as frequently as they had been in the past, but they should be basically around the same color as the rest of the mucosa in the mouth or the pharynx, the neck, or the back of the throat, not the neck, excuse me, the back of the throat. Sometimes there's like little crypts or little pockets, and there might be some little debris in there. When we talk about projection, that means how far do they stick out? And we talk about pillars, and you look at this little pictorial here. You have 1 plus 2 plus 3 plus 4 plus, and kind of have these pillars on the back of your throat. And you're kind of going to grade them from 1 plus, which is very small, to 2 plus to 3 plus is like almost kissing. Like if you look at this one here, this is nice and pink, that would be a 1 plus. If it's here with this peachy color, that would be what we would call a 2 plus. If they're really inflamed, that would be a 3 plus. If they are 4 plus, they are almost kissing. Again, that is a concern because, again, that's our airway. When you get to those tonsils that are 3 or 4 plus, that would be something you definitely want to let your provider know about. And that's basically how we grade the tonsils. The posterior wall of the oropharynx, or the back of the throat. Again, you're just going to inspect it. It should be nice and pink. It should be moist. It should be kind of glistening. Should have some smoothness. You might have a little of the postnasal drip dripping down. There might be some little spots of lymphatic tissue back there. You might see some little blood vessels. And again, some of that mucus from that postnasal drip, it might be clear, it might be yellow. It depends on if they have a sinus infection or what's going on. Some geriatric variations include increased vertical markings on their lips. Again, lack of collagen, losing some of that, the fatty tissue in their face. It kind of makes them a little bit more enhanced. The lips might be a little bit drier. The buccal mucosa is a little bit thinner and drier and less vascular, less shiny. Just over years of use, the teeth maybe appear a little bit worn down, and the gums tend to recede a little bit more with our geriatric clients. Their teeth look a little bit longer. Malocclusion is common because they just continue to kind of grow and overlap a little bit. And dark skin variations may include increased pigmentation of the buccal membrane in the gums. Again, it's going to be an association to what their underlying skin tone is. The tongue may appear a little bit more fissured, depending on some genetic traits. The veins on the ventral surface or the underside surface of that tongue may be more varicose and may be more prominent. You might see those veins a little bit more prominently. And there is your concept map for your mouth and oropharynx. Again, a lot of these things are not something you necessarily do for a normal head to toe. I do tend to ask my students to just have them look in their client's mouth, because it really does kind of like, for one, if you look at the teeth, you can kind of look into the picture of their overall health. Two, if you look at that oral mucosa, the tongue, that's really going to give you a very good indicator on how well hydrated your client is, or if they're at risk for fluid volume deficit or not getting enough fluid. Just in general, but we give you a lot of information here. If you have any questions, please don't hesitate to reach out to me.